I am Stephanie Radke. I'm an OBGYN at the University of Iowa, and I lead the AIM program in our state. We are funded by HRSA, as is AIM, so I put the disclosure up here that I'm really sharing kind of my opinion and our experiences in Iowa, not necessarily representing AIM or HRSA or various levels of government. So I was asked just to kind of talk about our experience, and then that sort of evolved to talking really specifically about collaborative quality improvement, which may not be something that people are as familiar with. And so I've kind of got that woven in as I talk about how we structured this work in Iowa. And then I have just kind of a few thoughts specifically about why I think that approaching this work as a state together can be really beneficial. So a little bit about me, I'm a clinical associate professor. I'm a general OBGYN. I practice at the University of Iowa. I'm from Iowa. This is where I went to school, but I did my residency in California and I practiced out there. And that was during the time that the CMQCC was getting started. And so I had the benefit of really training as an OBGYN in a standardized environment, which I didn't realize to be unique until I left. And so I didn't really I then started doing improvement work at my facility, and I now direct our QI here for labor and delivery. And then we were funded to start our program here in Iowa. I have an undergrad degree in psychology and an MPH in community and behavioral health, so I'm very specifically interested in human behavior and behavior change. I think that it is really a cornerstone part of quality improvement is trying to get people to do things a little bit differently than they've maybe done before, and that change management can be really exciting when it goes well, but sometimes a little bit painful when there's a lot of resistance. And then my professional training in quality improvement is all from the IHI. A bit about Iowa. Here we are. We have just over 36,000 annual births. We're a small rural state. Interestingly, we have 56 hospitals in our state that have labor and delivery units. And so when you kind of start to think about that math, it means that the majority of our units are very low volume. We only have about 10 hospitals that deliver more than 1,000 babies per year. The rest deliver under. And we have, it kind of varies a bit from year to year, but a good number of facilities, like 15 or 20, that deliver less than 250 babies per year. As you can imagine, these lower volume facilities are primarily staffed by family medicine physicians, so they have a little bit different training and ongoing education in OB. There are not very many OBGYNs that practice in rural Iowa. There are a few. And then similarly on the nursing side, in a lot of low volume facilities, which if you are from a low volume facility, this may be familiar to you, the nurses don't just work labor and delivery, they work all over the institution. And so they're kind of more generalists. And so on the nursing side, there may be less ongoing professional education in obstetrics. Many of our small hospitals do not have some of the nursing leadership positions that are really common in large and academic centers, such as a dedicated unit nurse manager who has a hired nursing degree, and most of them do not have nurse educators. We learned that most of our facilities, our low volume facilities, do not have staff who've completed or maintained formal certification or training in EFM, and that became a real important piece of this work in Iowa. And so this was our first initiative. 43 of our 56 hospitals participated in this bundle. We are wrapping up our work on obstetric hemorrhage, and we had all 56 hospitals work with us for that initiative. So I would say that our niche within the country is kind of how to work with really low volume facilities and make AIM work in places where the team composition and the practice may be a little bit different. So our journey, we were fortunate to receive funding from HRSA in the first cohort of the Maternal Health Innovation Award. And so we received that in 2019. We started by forming our quality collaborative, the Iowa Maternal Quality Care Collaborative, in 2020. And then we joined AIM in the fall 2020 cohort. We chose this bundle as our first initiative by popular vote of facilities, which was a little bit of a surprise. I almost didn't put it on the poll. I thought we would start with hemorrhage, but this was what people had interest in working on. And so we listened, and it turned out to be a great first bundle for us to get to know our facilities and for us all together to learn how collaborative quality improvement works and how AIM works. We launched our collaborative in May of 2021 with our first learning session and continued through July of 2022. We did have 1 month that we completely halted any activities because of the Delta surge of COVID, and we were certainly very gracious in understanding that people's work was going to be limited at times. And so we finished this bundle last summer, and we have been in program evaluation recently. Similar to you all, we use our state birth certificate records as our outcome measure data source. And so we had to wait until we could get the official measures from 2022, which wasn't until April of this year. So we are just moving through program evaluation right now. So I think there's some benefits to, I've considered us a little bit of a late adopter to this national movement, and we've really reaped a lot of benefits from that. Collaborative quality improvement is all about sharing great ideas, and we stole a lot of great ideas, borrowed them from other people who had already done this work. And it sounds like you guys are taking some good ideas from Illinois, who has recently come through this bundle as well. We follow the IHI Breakthrough Series collaborative model, which I think is becoming increasingly popular. And I heard reference that you guys are going to have a learning session, so it sounds like you may be doing that as well. We considered the role of unit culture and how that impacts cesarean practices and labor management practices. We utilized the labor culture survey, which was developed by Dr. Emily White Van Gumpel. She now practices at North Shore in Chicago, but she developed this tool while working, doing a fellowship with CMQCC. We talked to our neighbors in Nebraska who had a lot of experience working with low volume rural facilities and learned from them about the value of one-on-one facility coaching. And so that is really a cornerstone of our work in Iowa, although it's not technically part of the Breakthrough Series model. We really focused on dividing out unplanned cesareans for arrest of labor as the primary indication versus fetal concerns, and looked at those actually separately in our process measures. And then we did a lot. We heard from nursing about things that they liked that helped them promote normal labor progress. And we ended up adding a lot of workshops that we were able to pay for spinning babies and other labor positioning things. And then as we've been in program evaluation, we've appreciated what other states have published about how they evaluated their work. And that's helped us think about how we want to evaluate this bundle in Iowa. So all of that to say, share ideas with each other, and for your leadership, steal ideas from other states, because everybody's kind of doing the same things. And there's lots of great ideas out there. So in Iowa, as I mentioned, we followed an adapted Breakthrough Series model. It was fully virtual for this first collaborative, although subsequently we have our hybrid and we do some events in person. We offer team coaching on quality improvement, and we teach the model for improvement as our improvement methodology. And that was new for, I think, all of our facilities. I think really the use of process measure data was a newer concept for a lot of facilities. So if some of that is feeling new to you, you are not alone, and you'll become savvy with it. So this is the Breakthrough Series collaborative kind of visual depiction with the planning, the development of the changes, and really what are the best practices. The participants have pre-work, and then traditionally you come together 3 times for learning sessions. And so this is when we had ours. And then in between the learning sessions are considered action periods where the quality improvement work happens. And during that time, we would host a monthly call where we would present a short topic related to the bundle, and then we would spend the second half of the meeting hearing short presentations from facilities about things that they were doing that they had found success with. So the model for improvement is IHI's model for quality improvement. You can consider it akin to lean or some of the other methods that are out there. I think they all have a lot of very similar principles, but this is what we taught. So relating it to AIM, we all know that we're trying to reduce C-sections in a way that's safe. And so thinking about at the facility level, what your goals might specifically be. We want to use our data, as was just being presented, to help us understand, especially those process measures. Where do we have room for improvement? Where are we already performing well? And we probably don't need to put attention to it, but where could we be improving? So if we're doing really well with when we decide to do a C-section for concerns about fetal well-being, but we're, maybe not giving people enough time and calling a lot of arrest of labor conditions, then we want to focus on that, not so much on things where we're already performing well. And then what do we do differently? And so the nice thing about doing quality improvement work within the context of AIM is that they've already brought together a huge list of best practices, and certainly don't need to try to do all of them, but thinking about which changes will be most meaningful for your facility and most achievable, and that would be where I would suggest you start. And then using plan, do, study, act cycles to test out things that are going to be different. If you're looking at changing how you do something or introducing a tool, trying it out with one provider and really kind of perfecting how it works before you kind of mass educate and go live. This was a big change in how to introduce new practices for our facilities, but I think it can be helpful because you can avoid having challenges on the back end where there's some unforeseen problems. And then we promoted, use of repeated PDSA cycles. I just grabbed this slide from one of our presentations about using a pre-cesarean checklist to make sure that the C-section is really indicated, testing it with one person and seeing how that goes. When do you do it? Where do you do it? How do you document it? And then kind of scaling up and adding additional providers until you feel really confident that that tool is ready to go live in your institution. And then relating that QI method to the way that AIM sets up their measures, they follow a Donavedian model of structure, process, outcome, or SPO, with the idea that you need to have your necessary structures, right? You have to have educated people, the right skills and equipment, policies that promote the best practices. And then the process is making sure that we're really following them, right? We might have a policy, but what portion of the time do we follow it? And if you don't measure this and you try to just go from structure to outcome, you may not see your outcomes really improve, because if your structures are not really being put into practice, then you haven't really affected your system. And so that's where using PDSA cycles and tracking your data, those process measures that were just listed, is really where you want to focus your energy, because there is going to be some random variation just in the number of patients who might be indicated to have a C-section month over month. But if you really focus on making sure the correct medical decisions are being made for everybody, then in the end, you'll get where you need to be. So I mentioned some things about us, but some things that I think we did that might be a little bit unique is we did actually really invest quite a bit in education. We learned that there was a need, especially in our small facilities, for education. And so we ended up offering quite a bit of education around electronic fetal monitoring, including tapping into our network of A1 instructors to offer courses and offer people the opportunity to register for courses. We couldn't financially afford to pay for people to go through all those courses, but we were able to facilitate access to EFM instructors. And then we offered some webinars that offered CEUs, but weren't, an official, intermediate course. I mentioned we offered Spinning Babies workshops, and this was a great way to drive engagement because people would have a lot of fun at these workshops. They were free. We got our state A1 and ACOG to offer lunch, and people just got more engaged in the project, brought the skills back to their facilities, and then often were able to work with facility leadership to bring additional training to their whole facility. We did do one virtual workshop that worked fairly well, which was on using a peanut ball for positioning primarily of patients who have an epidural. And since it was virtual, we had unlimited attendees, and we were able to distribute the recording and keep it live for up to 30 days after. And then we facilitated often me or other people coming to speak to facilities if there was people feeling like they needed to have somebody else as the messenger of the work. And so I think that's another benefit of this, is being able to tap into your local experts in your state to speak at facilities, particularly if people are having trouble getting engaged in the project. We offered for teams to use a labor culture survey. About 2/3 of our facilities chose to do that, and we facilitated distributing that, evaluating it, and putting together a report for each facility with which involved a contract with Dr. White Van Gumpel, but I think was really helpful. It helps you understand kind of the values that people working on your unit may have, and it might be different than you would expect. And then really we just listened to people, especially being this was our first collaborative, and it was largely during waves of the pandemic, just kind of hearing from people what they needed from us in order to achieve success. So I mentioned that we're kind of in program evaluation right now. So sharing some of our results, similar to what it looks like you guys are doing, granted, we went through the bundle during the previous iteration of the bundle. It's since been updated, but we added a few bundle elements, not quite as many as you guys have, but I think your list looks great, that we asked people to work on. And so of our hospitals, which I realize there's a typo on here, this is 44 hospitals or 43 that participated. The majority of them implemented practices that promoted family-centered cesareans when they did need to happen, and engaged with patients as QI partners. You can see that 2/3 introduced that checklist. I think that's probably one of the most important components of the bundle. Most got multidisciplinary case review conferences going to review unplanned cesareans. Many were able to integrate some of these tools into their EMR. And then many policies were revised about labor support and patient and family support. And then looking at people who worked on but did not fully implement things, we see again, policies sometimes didn't quite make it across the finish line, but work is in process. Same with multidisciplinary case reviews. Some of these things are a little bit harder to put into place, and a lot of them do carry across multiple bundles. So teams are still working on these things. We divided our reporting a little bit differently than other states. So we, in that process measure of looking at what portions of C-sections were indicated or met criteria, we divided that out, and we had people look at non-progressive labor C-sections and versus those performed for fetal concerns. And then we had our facilities that deliver more than 1,000 babies per year actually look at their data monthly, whereas everybody else would look at data quarterly because they would not have enough cases to review monthly. And so you can see, especially for our quarterly reporting facilities, there was really significant improvement over the course of the collaborative. And for our higher volume facilities, interestingly, we also saw a lot more improvement in how people were interpreting fetal heart rate patterns, more so than as much movement on non-progressive labor, but they tended to be performing a little bit better on that from the beginning. And so that may relate to having more obstetrician gynecologists in these facilities, or just generally more people around, more standardization. I don't know the reasons why there were differences from the beginning. One of the things we're looking into, but overall both groups had quite a bit of success. Our goal was to get to 95%, which is a really, really lofty goal. You can see we got fairly close with the C-sections being performed for concerns for fetal well-being. Looking at our outcome measure quarterly, so this is the entire state of Iowa, so it includes the hospitals that didn't participate. We kind of hung around 24, 25%. Even looking back previous years, we've been pretty stable around there. So a little bit better than the national average, but not quite meeting healthy people targets. And then we had really nice improvement during the time of the collaborative, and then a little bit of an uptick. So some sustainability challenges following conclusion of the collaborative, but then we've since seen it come back down. And then into 2023, provisional data is looking like we're coming back down a little bit more. So we feel as though we did affect change in our state, but with all things, not every facility was able to sustain every component, and not everybody participated. Looking at our participatory versus our non-participatory facilities, I think something that was really interesting is this was during a big peak of COVID. And it seems like our facilities that weren't working with us and weren't really keeping their eye on these practices really had a big upswing in their C-section rates during a big Delta wave in Iowa, whereas our facilities that have been working on this, they were able to just kind of maintain consistent practice and have kind of a general decline. That was interesting to look at. And then doing just kind of a more traditional before and after assessment. So we see that in calendar year 2020, our statewide NTSB C-section rate was 24.9, and in 2022, it was 23.3. So that was a statistically significant decline. For us, the largest decline was really amongst our Medicaid or self-pay patients. So similar to you all, we are interested in how this improvement work is experienced by everyone and want to make sure that people in most need of experiencing improvement are experiencing it. So we had a reversal of the kind of the disparity, the economic disparity between more privately insured patients and those with public insurance. So we are really excited about that. And then we see that while we did not completely close some of our disparities by race and ethnicity, the gap is a little bit smaller, and we did see improvement for our non-Hispanic Black and non-Hispanic other races populations. So we were pleased with that as well. So kind of my last thing as I get through my final 2 minutes here is just a few more thoughts about really the collaborative improvement component. I've mentioned this kind of before with how we took ideas from other states. I think that, if a good idea happens or something goes really well at one facility, that will likely work well at another facility, or at least spark some ideas of how that idea could be adapted at that facility. And so really using your statewide collaborative in whatever platform works best, if that's sharing on monthly calls or an email listserv, really encouraging people to share when they're having a success, because your success, it might seem really small, but it might be exactly the idea that somebody else needs to hear. I do think that when you're in communication, there's a little bit of friendly competition, which is a good thing. We never made people feel badly if they weren't making improvement or they're facing challenges, but I've observed that people were a lot more motivated to work on this because they felt, a sense of ownership of the larger project at the state level, and kind of shared responsibility to get the project completed. Especially going through COVID, the peer community that was created amongst our nursing leadership at different facilities was incredibly valuable. A lot of people, I think, felt very isolated in their facility. They didn't have peers in their facility because they were small, and so they don't have another nurse manager that they could, it's not a nurse management team, it's one person. And so I think giving people an opportunity to communicate, and we see our listserv being used for all sorts of things. There's a big thread going on this morning about whether or not people require anesthesia to stay in-house when they're running an epidural in these small hospitals where they're not generally in-house 24/7. And so creating opportunities for people to communicate and ask questions and quickly gather information has proven really, really valuable. And then I mentioned a few things about what we did to support education. And I think creating shared educational resources, sharing presentations, knowing who are your experts in your community that could maybe be tapped to go over to another hospital and give a noon conference or virtually give a talk, or just who even, who are your A1 instructors, can be really valuable for people who don't know how to access all of those resources. And I think in general, you just kind of reduce some repetition. We break down some silos. You don't need to solve every problem yourself. Somebody else may have solved it somewhere else, and you just need to find their answer because it may be your answer too. All right, I did it right at 25 minutes. So I'm very happy to take any questions. My email address is here as well. If anybody thinks of something or would like to email me, I would welcome that as well. So thank you very much.